Hello, fellow warriors. Here we are with news from the website prostatewarriors.com.
It is great to be here.
So, I want you to imagine a general, right, trying to win a war by ordering this massive, indiscriminate bombardment of an entire country.
Right, just leveling everything.
Exactly. All while the actual enemy forces are, only hiding inside maybe 3 specific buildings.
Which is a terrible strategy.
It really is. But for a very long time, that was kind of the reality of cancer treatment. We treated the whole body and just sort of hoped the cancer took the worst of it.
Yeah, we basically did. But today, we are witnessing this profound shift in oncology.
And that's exactly the mission of our deep dive today, to explore this rapidly evolving, hyper-personalized frontier of prostate cancer research.
It's an exciting time because the focus is no longer on that static, one-size-fits-all playbook.
Right. We actually have a stack of clinical trials and new studies in front of us, and they show how doctors are learning precisely when to strike, where to strike, and exactly how hard to strike the disease.
And tailoring that for each individual patient. We're analyzing treatments that actually adapt in real time.
Right, reading the biological feedback of the tumor you were fighting and then adjusting the attack.
Yeah.
Now, because finding actionable real-world treatments is the absolute priority for you, the listener, we're going to be looking at the clinical trials first.
Always best to start with what's happening right now with actual patients.
Exactly, not just theories in a lab. Okay, let's unpack this, starting with the ARTO Phase 2 trial.
Right, so the Phase 2 AR2 trial, this was conducted in Italy and involved 157 patients.
And this was for a very specific disease state, right?
Yes. The focus here was on oligometastatic castration-resistant prostate cancer.
That's a mouthful. Let's break that down for everyone.
For sure. So oligometastatic basically means the cancer has spread beyond the prostate, but only to a few visible spots, usually just up to 3 or 5 lesions.
And the castration-resistant part, the mCRPC, that's a major biological threshold, isn't it?
It is. It means the cancer has mutated to survive, even when we reduce the body's testosterone levels to almost 0.
Like the cancer essentially learns how to create its own fuel, or it changes its receptor so it doesn't even need the testosterone to grow anymore.
That is exactly the mechanism. So in this trial, the standard systemic therapy for these patients was a drug called abiraterone combined with standard androgen deprivation therapy.
Which is meant to severely block hormone production across the entire body.
Right, but the researchers wanted to see what happens when you add metastasis-directed SBRT to that systemic therapy.
And SBRT stands for stereotactic body radiation therapy.
Correct. And unlike older radiation that just treats these big, broad areas, SBRT uses dozens of intersecting beams to deliver a really massive 3D sculpted dose of radiation.
Right, to those specific visible spots. It's kind of like a hammer and anvil strategy.
Oh, I like that analogy.
Yeah, so the systemic therapy, the abiraterone, that acts as the anvil, right? It weakens the whole system by depriving the cancer of the hormones it needs to thrive everywhere. And then the SBRT is the hammer. It just comes down and completely smashes those visible strongholds that are trying to take root in the bones or the lymph nodes.
The data actually strongly supports that analogy, because after a median follow-up of 53 months, the median overall survival in the control arm—
the patients who only got the systemic drugs.
Exactly. Their median overall survival was 50 months. But in the SBRT arm, the group that also received the targeted radiation, the median overall survival was not reached.
Wait, meaning not enough people in that group had passed away to even calculate the median?
Yes. The hazard ratio for death was 0.55.
Wow.
Yeah. In biological terms, by crushing those macroscopic strongholds with radiation, you drastically slow down the disease's ability to mutate further and spread new seeds.
So the risk of death was practically cut in half.
Almost in half, yes. And crucially, there was no clear excess in serious toxicity from adding that targeted radiation.
Which is huge, but why is this so critical for patients to understand?
The reason you should care about this is that proving an overall survival advantage is notoriously difficult in this specific disease setting.
Because they usually end up getting a bunch of other treatments later on, right?
Exactly. Patients with this profile typically go on to receive multiple sequential therapies down the line, like chemotherapy, radioligands, and that usually muddies the data.
Right, it makes it hard to know what actually worked.
Exactly. So seeing a clinically meaningful separation in overall survival over 4.5 years of follow-up, that is a definitive signal.
That's incredible. But if the hammer of targeted radiation is that effective, it creates a new biological puzzle.
How so?
Well, how do we avoid swinging that hammer too many times? I mean, you want to smash the strongholds, but you definitely don't want to destroy healthy tissue by overtreating the patient.
That is a perfect transition, because that brings us to the RIPCORD Phase 1 trial out of UT Southwestern.
Okay, let's get into this one.
So this trial looks at polymetastatic castration-sensitive disease. Let's define those parameters real quick.
Yeah, polymetastatic means a widespread disease burden, right? Way more than just a few isolated spots.
Exactly. And castration-sensitive means this cancer hasn't mutated yet. It still relies heavily on testosterone to grow.
Okay, so what's the treatment approach here?
They are using SABR, which is stereotactic ablative radiotherapy. It's very similar to SBRT. But the twist is they administer it in weekly pulses, and they actually adapt the dosage based on real-time biological feedback.
Really? How does that adaptation actually play out during the patient's timeline?
So after 3 pulses of radiation, which happens about 6 months into their standard systemic treatment, the treatment halts.
They just pause it.
Right. And then the medical team performs a 68G PSMA 11 PET scan.
Okay, PSMA, prostate-specific membrane antigen. It's basically a protein that sits on the surface of prostate cancer cells like a little flag.
Exactly like a flag. And the radioactive tracer in the PET scan binds to that flag and lights it up on the imaging. So, if that scan shows a complete metabolic response, meaning the lesions are no longer active and the flags are gone, the radiation stops entirely.
Wow. And if it's not clear?
If there is residual disease showing up on the scan, they administer 2 more pulses of radiation to those stubborn areas.
Okay, I have to push back a little here, though. Are we really confident that a clear PET scan actually means the cancer is totally gone? I mean, could it just be hiding below the detection limit of the machine?
That is a very valid point.
Because stopping radiation when you're dealing with widespread metastatic disease, that seems incredibly brave.
It is a significant biological concern, which is precisely why this is currently just a Phase 1 trial.
Yeah.
We definitely have to verify if microscopic disease is lingering.
Right.
But what's fascinating here is that we are moving beyond just using imaging to predict long-term outcomes and actually using it to dictate treatment intensity in real time.
Which is a huge shift.
It is, because PSMA PE scans are vastly more sensitive than traditional bone scans or CT scans. By using the scan as an active compass, the goal is to spare patients the cellular toxicity of overtreatment.
By not treating lesions that are basically already biologically dead.
Right. Concentrating firepower only on the pockets that are actively resisting therapy in polymetastatic disease, that's a major conceptual leap.
It really is. But the RIPCORD approach totally relies on the cancer cells actively flying that PSMA flag.
Yes, it does.
And we know tumor biology is tricky. What happens if a patient's tumor mutates and just doesn't express PSMA strongly?
That is the known escape mechanism for the cancer, and it's exactly where the A90631 and A90642 trial enters the picture.
Okay, this is the Phase 1/1b trial, right?
Yes, it's a first-in-human Phase 1/1b trial targeting an entirely different cellular receptor called GRPR.
Gastrin-releasing peptide receptor.
Exactly. Normally, this receptor is involved in releasing hormones in the gut, but prostate cancer cells often hijack it. They overexpress it on their surface to promote their own growth.
Ah. So we basically bypass the PSMA flag entirely and look for the GRPR flag instead.
Yes. And this trial utilizes what we call a theranostic platform.
Which is a combination of a diagnostic imaging tool and a therapeutic radioactive tool. The whole philosophy is, if you can see it, you can treat it.
Spot on. So first, they use an imaging agent called 68GA-A96272. This binds to those GRPR receptors and lights them up on the PET scan.
Okay.
And once the targets are verified, they send in the actual therapeutics, either 177-Lu-A90631 or 225-ACA90642.
Let me jump in with an analogy for those two types of radiation, just to make it clear.
Please do.
So beta emitters, like lutetium-177, they're often described like a wide radius grenade. You know, you drop it in and it clears out a localized area. But alpha emitters, like actinium-225, they're more like a highly intense, close-range sniper shot.
Those metaphors accurately describe the clinical results, but let's look at the physics of why that actually happens.
Yeah, let's hear it.
So lutetium-177, the beta emitter, it fires off an electron. Now, an electron is very light, so it travels a few millimeters through the tissue, hitting multiple cells in its path.
Right, like a grenade's blast radius.
Exactly. It causes single-strand DNA breaks. It is highly effective for controlling tumors while sparing most healthy tissue. But actinium-225, the alpha emitter that fires off a helium nucleus,
They're just much bigger.
massive. It's massive and heavy compared to an electron. Because it's so heavy, it only travels a few cell diameters before it just stops. But it deposits a massive amount of energy, causing catastrophic double-strand DNA breaks.
And the cancer cell just cannot repair that kind of damage.
No, it can't. So by testing both an alpha and a beta emitter against the exact same GRPR target, researchers are comparing two vastly different radioactive payloads within a single platform.
That is so cool. But here's where it gets really interesting, though. All the trials we just walked through, they're targeting advanced or metastatic disease.
Right.
But what if we bring out the heavy artillery earlier?
You are referring to the phase 1 trial combining 177-loop PSMA 617, which is commercially known as Pluvicto, with a drug called Darolutamide.
Right, administered in the neoadjuvant setting, meaning before the patient ever even goes into surgery.
Exactly. Neoadjuvant refers to administering a powerful systemic therapy before the primary localized treatment. And for these high-risk localized prostate cancer patients, that primary treatment is a radical prostatectomy.
The surgical removal of the gland.
Right. The biological rationale here is to launch this intense dual mechanism attack while the cancer is still mostly confined to the prostate, but where the risk of microscopic spread into the surrounding tissue is really severe.
So how do the two drugs work together?
Well, darolutamide works by aggressively blocking the androgen signaling that the cancer feeds on, and concurrently, the 177-loop PSMA 617 binds to the cancer cells and delivers that beta radiation we just talked about.
So you are basically starving the tumor with darolutamide while simultaneously radiating it from the inside out with lutetium to kill off any microscopic spread. But I do have a logistical question here. If you intensely radiate the prostate gland inside the body, doesn't the resulting tissue damage make the actual prostatectomy much more complicated? I mean, radiation usually causes scarring and fibrosis, which surgeons typically want to avoid, right?
That is a very real concern. The potential for surgical complications is significant, which is why the primary endpoints of this phase 1 trial revolve entirely around safety and dosimetry.
Dosimetry, meaning measuring the exact absorbed dose of radiation in the tissue.
Right. The medical team needs to ensure they are delivering enough radiation to kill the cancer, but not so much that the prostate fuses to the surrounding nerves and bladder.
Because that would make surgery practically impossible.
Exactly. But the ultimate goal makes this risk worth investigating. If this combination can deepen the pathologic response, meaning we actually eradicate most of the active cancer cells before the scalpel ever touches the skin, we vastly reduce the chances of early recurrence.
So we shift the whole paradigm from just managing a chronic disease to attempting a definitive cure right off the bat. Okay, so we have spent the first half of this deep dive learning how researchers are escalating treatment through combination therapies and adaptive radiation. But how do we figure out who actually needs less treatment?
Right, avoiding overtreatment.
Yeah, because no one wants to endure the physical toll of radiation, chemical castration, or surgery if their specific biology just doesn't warrant it.
This is where we look at the Oxford GPS PROMPT retrospective study.
Okay.
This study analyzed the 17-gene genomic prostate score, referred to as GPS-MDX.
So instead of just looking at the cancer under a microscope, this test actually analyzes the RNA expression of 17 specific genes within the tumor tissue itself.
Yes. Genes that control things like cellular organization, the androgen response, and cell proliferation.
And what did they find?
The researchers analyzed over 400 patients and found that this genetic score consistently predicted oncological outcomes. Scores of 25 or higher predicted clinical failure for men on active surveillance. And scores of 40 or higher accurately identified those at high risk for biochemical recurrence events.
Which is when a patient's PSA levels begin to rise again after their primary treatment, indicating the cancer is coming back.
Right. So a high genetic score strongly correlates with treatment failure and recurrent disease.
But there was a massive subgroup of men in this data that completely defied traditional expectations.
There was. Nearly half of the men who were categorized in the higher NCCN clinical risk categories actually had a low GPS genetic score.
And the NCCN categories are how doctors traditionally stage the danger of the cancer based on clinical features, right?
Yeah.
The PSA blood level, the Gleason score from the biopsy, the physical stage of the tumor.
Exactly.
It's the ultimate example of judging a book by its cover. Clinically, on the surface, the tumor looks highly aggressive, like a tiger. But when you look at the genetic code, it's just a house cat.
That's a great way to put it. To put a finer point on the mechanism, think of it like evaluating a car. The clinical features, the NCCN categories, are like looking at the exterior of the car.
Right. It might have a massive spoiler, racing stripes, an aggressive body kit. It looks incredibly fast and dangerous.
Exactly. But the 17-gene GPS test is like actually opening the hood. And when you open the hood on these specific tumors, you find a lawnmower engine.
They just don't have the horsepower to spread.
Right. They simply do not possess the biological horsepower, the genetic mechanisms for cellular proliferation and metastasis to spread aggressively. And the outcomes for these patients proved it.
The numbers were wild. Despite having unfavorable clinical features, their 6-year event-free survival was between 88 and 100%, even when utilizing less aggressive treatment approaches like active surveillance.
It's a staggering implication.
A huge portion of men who might currently be pushed toward aggressive surgery or radiation based on their clinical staging could potentially avoid all of those side effects and be totally fine just watching it.
We must highlight a critical constraint here, though. This was a retrospective study.
Meaning they were looking backward at historical data.
Yes. Before this changes standard clinical practice, it requires rigorous prospective validation. We need to conduct a trial where we make treatment decisions based on the genomic score in real time and observe the outcomes.
Which is currently happening with the GPS Protect trial, right?
Yes, it is. But the biological implication remains profound. Evaluating the tumor's genetic engine is likely far more informative than just looking at its clinical exterior.
But what if the genetic code shows the tumor does have a massive engine? Like, it is highly aggressive and resistant to radiation and hormones. How do we recruit the patient's own immune system to fight back? Because historically, prostate tumors have been notorious for hiding from immunotherapy.
They have. Prostate tumors are typically what we classify as immune excluded.
What does that mean exactly?
It means even if the tumor is growing rapidly, the body's immune cells either cannot penetrate the tumor microenvironment or they just fail to recognize the cancer cells as a biological threat. The immune system literally ignores them.
But there is a new preclinical breakthrough demonstrating how we might breach that defense, right? By combining a PRP inhibitor called olaparib with a novel T-cell agonist called STAR-0602.
Yes, it's a fascinating combination.
So how do those two specific drugs work together mechanically to break into an immune-excluded tumor?
Let's start with olaparib. It is a PRP inhibitor, meaning it blocks an enzyme that cancer cells use to repair damaged DNA.
So when the cancer cells can't repair themselves, their DNA becomes chaotic.
Exactly. They start accumulating these fragments on their cell surface called neoantigens. The tumor cells begin to look biologically alien and cluttered.
Which makes them much more noticeable to the immune system.
Yes, but simply making the tumor noticeable is not enough. You have to actively recruit the immune cells to the site.
And that is where STAR-0602 comes in.
Exactly. STAR-0602 is a bifunctional T-cell agonist designed to deliver interleukin-2, or IL-2. If we connect this to the bigger picture, administering systemic IL-2 therapy to a patient is historically highly toxic.
Because it activates the entire immune system all at once, right? Leading to a dangerous cytokine storm.
Precisely. However, STAR-0602 is engineered to selectively target and expand only very specific subsets of immune cells, specifically memory CD8 positive populations that express certain T-cell receptor variable beta chains, or TCRV beta chains.
So it acts like a highly targeted megaphone, basically waking up only the exact immune cells capable of attacking the cancer while completely avoiding that systemic toxicity.
Yes. It avoids the widespread chaos of typical IL-2.
The study actually notes that this process creates a durable polyclonal immune response. Can you give us a plain English translation of the biological difference between a polyclonal response and a monoclonal one?
Sure. A monoclonal response involves expanding one single highly specialized type of immune cell to look for one very specific neoantigen target on the cancer.
Like sending in one specialized sniper.
Right. But the biological flaw there is that if the cancer mutates and stops displaying that specific target, the immune response becomes useless.
So what about polyclonal?
A polyclonal response, which is what this therapy generates, involves recruiting multiple different lineages, or battalions, of the immune system. Each battalion is trained to recognize a completely different neoantigen on the surface of the tumor.
So even if the tumor mutates and changes its disguise to evade one battalion, you have multiple other battalions that still recognize the chaotic DNA and destroy the cell.
Exactly. It promotes a biological cascade called antigen spreading. And importantly, because this targeted therapy expands stem-like progenitor-exhausted CD8-positive T cells, the resulting immune response is highly durable.
Meaning the immune cells establish a memory of the cancer. They stick around in the patient's system over the long term to prevent the microscopic disease from taking root again.
Precisely.
Okay, let's take a breath and survey the landscape we just covered.
They covered a lot.
We really did. We started by exploring how clinicians are adapting stereotactic radiation in real time, dictating treatment intensity based on PSMA PT scans. Then we unpacked how researchers are bypassing PSMA entirely to target GRPR receptors with precise alpha and beta radiation. Right. We looked at how analyzing the 17-gene engine under the hood of a tumor can save a patient from the physical trauma of unnecessary overtreatment. And we ended by detailing the mechanics of combining PRP inhibitors and targeted IL-2 delivery to launch a massive polyclonal immune assault on resistant tumors. So what does this all mean?
It means the era of blind bombardment is ending. Consider the trajectory if we can combine highly accurate genetic sequencing, like the GPS score, with bioengineered tools that program a durable polyclonal T-cell response tailored to those specific genetics. Well, we are approaching a horizon where prostate cancer is no longer just managed as an inevitable chronic disease.
Wow.
We are moving toward a future where we can design a bespoke, personalized vaccine to cure the unique biological profile of every individual patient's tumor.
A biological cure as unique as the patient themselves. Thank you for joining us as we analyze the science that is actively changing the world. Stay strong and fight on.